Hi, this is Dr. Mal Sayed. Welcome back to the lecture series of Let the X-rays Talk to You. Today we will talk about the three types of intraoral radiographs, but in detail we will be talking about the periapical radiography. The intraoral radiography is of three types: the periapical radiographs, the between radiographs, and the occlusal radiographs. For all these type of radiographs, when we are going to take these radiographs, we have to prepare the patient. The patient is seated in an upright position in the dental chair. The patient is instructed to remove eyeglasses, all removable dental appliances, and any metallic piercing or jewelry that may be in the path of the X-ray beam. Metallic objects that have been left in their place will attenuate the X-ray beam to produce radiopaque shadows, superimpositions on the image. So we have to be careful, which may obscure important structures. The patient is covered with a lead apron and thyroid collar. We also take care of the infection control protocol. During the production of radiographs, the operator should wear gloves and adhere to all standard infection control procedures. We also take care of the radiation hygiene. Radiographic prescription should be based on the standardized guidelines of the American Dental Association and in accordance with the ALARA as low as reasonably achievable principle of radiation hygiene. We also have to prepare the receptor. Either digital or film type receptors can be used to capture the image. These days mostly we are using the digital type of receptors. So different type of digital receptors. We know that there is a solid state charge coupled device, complementary metal oxide semiconductor, and photo stimulable phosphor. So it is important to note that for infection control purposes, digital receptors must be wrapped in single-use plastic sleeves prior to intraoral placement, while film-type receptors come from the manufacturer as a pre-packaged sterile unit. So we have to take care about the digital ones, most important, and it's very important to take care of the digital type of receptors. We have to cover them, wrap them with the single-use plastic sleeves. As I told you earlier that we will be discussing more about the periapical radiography. So the periapical radiography, it describes the intraoral techniques designed to show individual teeth and the tissues around the apices. Each image usually shows 2 or 4 teeth and provides detailed information about the teeth and the surrounding alveolar bone. Main indications. The main clinical indications for periapical radiography include the detection of apical infection or inflammation, assessment of the periodontal status, after trauma to the teeth and associated bone, assessment of the presence and position of unerupted teeth, assessment of root morphology before extractions, during endodontics, pre-operative assessment and post-operative appraisal of apical surgery, detailed evaluation of apical cysts and other lesions within the alveolar bone, and evaluation of implants post-operatively. Now we come to the ideal positioning requirements of a periapical radiograph. The tooth under investigation and the image receptor should be in contact, or, if not feasible, as close together as possible. The tooth and the image receptor should be parallel to one another. The image receptor should be positioned with its long axis vertically for incisors and canines and horizontally for premolars and molars with sufficient receptor beyond the apices to record the apical tissues. The X-ray tube head should be positioned so that the beam meets the tooth and the image receptor at right angles in both the vertical and horizontal planes. And last, the positioning should be reproducible. Radiographic techniques. The anatomy of the old cavity does not always allow these ideal positioning requirements to be satisfied. In an attempt to overcome the problems, two techniques of periapical radiography have been developed. Number one, the paralleling technique and the bisected angle technique. This is the image showing the paralleling technique. This is another diagram showing the same technique. These are the positioning for the holders. How can we use the holders for positioning for all type of teeth, for the upper, right, left, and lower right and left. And this is another image showing how we can use the holder for other teeth. Now, this is the image showing the bisected angle technique. So how we are going to place the X-ray and how we are going to use the X-ray beam for taking bisected angle technique radiograph. Fine. Now we will continue with identification of some dental anomalies and pathologies on dental X-rays, and mostly we will be identifying these anomalies on periapical X-rays and some occlusal radiographs. So this is an X-ray showing some calculus on the molar on the distal side, and the arrow is showing you the calculus, and we should know that calculus is appearing radio opaque on the dental X-ray. So, and it depends on the density of the calculus how radio opaque it can appear on an X-ray. This is another X-ray. It's a bite-wing X-ray showing two teeth, and the arrow is indicating some incipient lesion on the distal side of the tooth, and the another arrow is showing some caries in the mesial portion of that tooth, and but the distal side shows some very initial stage of the caries, so it can be incipient lesion in this distal area, and the other arrow showing on the mesial surface of that tooth can be a carious lesion because it has gone a bit deeper. So this is another X-ray, and this is tooth number 30, and showing some decay, and we can see that more than half of that tooth is exposed to caries, so the dentin is damaged halfway, so this can be obviously a carious lesion. So, or we can say that it's an advanced decay. And above that tooth we can see some radiolucency. It's a restoration done on that tooth, so it is very white, very radio opaque. So we should know that the restoration on an X-ray appear very white and quite radio opaque. In this X-ray we can identify some recurrent decay due to improper restorations, and this arrow is indicating some cervical lesion in this lower premolar. Now have a look on this X-ray. The arrow is showing some type of radiolucency, a gray area
below the sound enamel, and we can uh, say that this can be some type of occlusal caries, uh, although the enamel is intact. So this X-ray is showing some occlusal caries here.
If we proceed further and have a look on the upper primary molar, and if we see the mesial surface of that molar, we can appreciate that there is a lesion on this mesial surface, and this can be a carious lesion in this primary molar. So that's why x-rays are very important in diagnosing the carious lesion or some other anomalies. This is also a radiograph showing a deciduous tooth and the dorsal surface, and showing some carious lesion. The arrow is indicating that lesion. So this can be a deciduous tooth decay. And now look on the upper teeth, that the 1-3 and 1-2 are overlapping each other, and there is a radiolucency in the interproximal area. This radiopacity or cannot be a carious lesion or something else, because this is because of the overlapping of these teeth. So this is called the Mack effect, and this is not any anomaly. This is another radiograph, and the arrow is indicating some overhanging restorations in this tooth and also in the other teeth. So these are not good restorations, and maybe we will look into this matter as we can go for some crowns for this one. So these are not good restorations. If we see above to the arrow, we can see that there is some radiolucency and dark area. So we can say that this can be some bone loss in that area. Now if we see this x-ray, the arrow is indicating some periapical abscess, and there is a radiolucency in this area. The radiolucencies can be of other reasons as well. There may be some granuloma or some other cyst as well. So, and we can see in the crown portion that the crown of this tooth is almost completely obliterated. And if we observe this the area of the pulp, or we minutely see the details in the pulp, there is pulp in fact is a radiolucent area, and we are identifying here that some radiopaque area is there in the pulp. So this can be some pulp stone. This is an x-ray showing an impacted third molar, and the direction of the crown is showing that this is some type of ectopic presence of the third molar, and this impaction can be of any reason, but this x-ray is showing us that this is an impacted third molar. Now this is an interesting x-ray showing some primary teeth, and below those primary teeth the arrow is indicating permanent canine impacted under these teeth. Usually this doesn't happen, but in some circumstances we can experience some impacted canine. and this is one of that x-ray showing us the impacted canine with a short root. Now this is the x-ray showing some dark area on the mesial surface of the tooth area. The arrow is indicating that area, and the arrow is showing some radio opaque thing, and this can be a retained root in this area. And we can see that the upper tooth, because of this missing tooth, the upper tooth has over erupted or super erupted, and to take the position, as we know, mostly wherever the tooth is missing, the upper teeth try to take that position and try to adjust the occlusion. Now check this x-ray. The three arrows are showing us that this is the area of the bone, alveolar bone, and the dotted line shows us the exactly the position of the teeth, and we know that the area is showing the radiolucency, or the dark gray area. There is some missing tooth, and that because of that the adjacent tooth has taken or tilted towards its mesial side and showing not parallel to the cemento-enamel junction line. So this is basically the tilting of the molar because of the missing tooth. So this is a radiograph showing a missing tooth and tilting of the adjacent molar. So now this x-ray is showing us some overhanging filling, plus the arrow is indicating some bone loss in the interdental spaces, and this can be documented as a crestal bone loss or alveolar crest bone loss. This x-ray shows some wider and fat root surface, and we can say that this can be hypercementosis. In this x-ray we see the premolar having a curved root. This type of root is called lacerated root surface, and in the molar as well we can see the other root, the distal root, can be dilacerated. This x-ray shows us a supernumerary tooth, but how can we diagnose it as a supernumerary tooth? If we see on the above surface of the tooth number 3, we can see the radiolucency showing the zygomatic process. So the zygomatic process radiolucency can tell us that this can be a supernumerary tooth. The arrow here pointing towards some type of horizontal line, radiolucent line, and this can be the fracture in a tooth, and we can see that some wire, Catalan wire, or holding these teeth together. But if we see in the apical area, there is a radiolucency as well. So in my opinion, this tooth has to be extracted in near future. And now about this x-ray. This x-ray is showing some material in the extracted site from where the tooth has been extracted, and maybe, or most probably, because of extra amalgam dropped into this area, or that extracted tooth had some amalgam filling. And clinically this type of situation is called amalgam tattoo, and while examining intraorally, this appears as a bluish gray on the tissue.